9 months from now, I'm sure we'll see a lot more of each other.
Alrighty, I'm gonna introduce Dr. Maddox real quick for grand rounds, y'all. All right, so Cody Maddox, PhD, is the training director and assessment psychologist here at the Boise VA. Dr. Maddox received his PhD in clinical psychology from Duquesne University in 2013. He completed his doctoral internship at Penn State Center for Counseling and Psychological Services. Dr. Maddox joined the Boise VA in 2013. He is a member of the Boise Center of Education in Interprofessional Collaboration, a clinical instructor for University of Washington School of Medicine, and he supervises the psychological assessment minor rotation. His clinical interests include group and couple psychotherapy, psychodynamic psychotherapy, existential psychology, pain management, as well as personality assessment utilizing both objective and projective measures. He is a national consultant for cognitive behavioral therapy for chronic pain, CBT-CP. His primary research interest is in process and outcome studies examining the efficacy of psychotherapy, as well as quality improvement projects. Boom, that is the intro I was given to read for Dr. Maddox. This is Bryson, I'm a psychiatry resident. I know Dr. Maddox from getting didactics from him, and he is almost single-handedly responsible for really increasing my interest in personality factors and how that kind of establishes assessments. And so really grateful to have him talk here today. Thanks so much, Dr. Maddox. Enjoy.
Thank you so much. Everybody hear me okay? Okay, great. I'm juggling a few windows here, so bear with me. But so yeah, my presentation is on ADHD diagnosis as I see it at the ground level in my clinic at the Boise VA. I'm hoping that that this will be helpful, not only understanding sort of how I go about that diagnostic process, some of the difficulties, but sort of how that fits into the larger treatment system and how that may apply to your own clinics, whether you're inside the VA or outside. The pre-survey I sent through recently, just right now, is just because I wanted to get a sense of where people are having difficulties. It's interesting. I think one of the things that happens depending on where you're at is that you see things, within your own view. And so for me, ADHD assessment and diagnosis has become a major issue. And I'll talk more about that. You can imagine why, given the title of the presentation being the LOGJAM. But looking at the survey, it looks like the majority of people are saying it's not a major issue. Some people mentioned that they're not in clinics, like, for example, in pain clinic, where they're not seeing a lot of these patients. For the people that indicate that it is looking like that it is an issue, for example, one individual said, patients who do not have childhood history of ADHD are coming into my office demanding stimulants or a continued stimulant started by a previous provider, specifically here PCP. Another person indicated that referrals to behavioral health for evaluation and confirmation of diagnosis, ADHD feels overdiagnosed. So let's kind of get into this here. We all know this history, but just to kind of frame this, I mean, ADHD obviously has been around in the literature for a long time, but it really wasn't until, I would say, like the 80s and specifically the 90s that it starts to get more awareness within the more awareness outside of academic and clinical circles. Certainly that has exploded over the last 10 years, or specifically the last 5 years, I would say, since COVID. Awareness of ADHD as well as autism has been quite on the rise. I attribute a lot of this could be attributed to things like TikTok and YouTube and different social media. But on the one hand, mental health providers have long looked for ways of getting more sort of like awareness of disorders and treatment to try to get to increase the number of people that are seeking treatment and getting help. But sometimes this has a double-edged sword, especially something like ADHD, which we'll touch on here in a little bit. Prevalence rates range usually between 2.5 to 5% in the general population. In the military, go away thing. In the military, we would expect that to be less, given that ADHD for a long time was a disqualifying condition. So that changed during the most recent conflicts, where it is still a disqualifying condition, but there are stipulations. So for example, if someone is able to function normally off of medication for at least 12 months, and they have a high school degree and they're able to get a 50 or above on their ASVAB, they can still get in. But regardless, we would expect to see lower rates of ADHD within our military population. However, that some studies indicate that's probably not the case. This is looking at people that are soldiers that are in service. So this is not veteran population, but this study, for example, found that ADHD was the third most prevalent disorder. And you have to remember too that in the VA, obviously we have a subset of military personnel that end up seeking care, so that could be more prevalent within our population. Less, I would imagine, to be more prevalent, but regardless, there's good indication that there could be, more individuals within the military population have ADHD than compared to general population. So that would seem to be the case. Actually, let me step back. So historically, my assessment clinic was a sliver of the clinical duties I had here. And the clinic was really designed to help people with very complex patients, typically comorbid personality disorders or strong personality traits, atypical psychosis. They were in-depth assessments that usually utilize like projectives and large tests, and were really meant to kind of help tease out real difficulties with these kind of more complex, severe mental health patients. And when it came to ADHD and other neurodevelopmental disorders like autism, we tended to screen those out of our clinic. So unless the referral was linked specifically to treatment goals, and treatment goals that were like specifically important to ADHD, for example, a veteran gets out of the service, they go through PTSD treatment. It looks like they have a clinical history of ADHD. They're wanting to go back to college. They really want to have a better understanding of their strengths and weaknesses. If they meet criteria, maybe get some accommodations for school. Like that would be a referral we would tend to take historically. But if someone was, in their mid-40s, let's say 100% disabled, not working, has a history of depression, fairly well treated, maybe not, but they may have ADHD, we wouldn't typically take that case. We would decline it. That really changed in 2020 because of the large increase in referrals. It seemed like many of our providers on our BHIP team, specifically in psychiatry, were getting swamped by many of these cases, and we felt like we couldn't just simply say no to the increased referral rates. And so we changed our clinics around and began to open the doors to ADHD referrals. What you see on the right is the percentage of different presenting issues within the consult. These aren't all in a consult. Obviously, I'll get something like ADHD versus PTSD, or ADHD, PTSD, bipolar disorder, or something like that. So, these are taken from the consult. It's not perfect data, but it gives you a sense that this was, I think, from late 2020 to 2023, about 41% of my referrals quickly turned into ADHD referrals. If you add in the autism referrals to that, you're looking at about 51% of total referrals to the clinic being about neurodevelopmental disorders, which is a lot. in preparation for this presentation, I reran the numbers in 2024. So this is from Jan 1, 2024 to current. And ADHD referrals have increased. So I'm now looking at about 51% of mine. So over half of the referrals to the clinic are now ADHD, 8% are for autism. And then you have what I would consider more of the traditional diagnoses that I would normally assess. I also keep track of everybody's names who send me patients. So, and I try to do my best, because obviously when you have, a lot of referrals, I sometimes like, who is this person? But as best as I can put it together, about 38% of those are coming from psychiatry, 30% from BHIP, and 23% from primary care. The primary care referrals are typically from ICT, so our PCMHI folks, but some are coming directly from primary care providers. And we're going to talk more about sort of like the algorithm of care throughout our healthcare system, because that is one of the potential things I think we should really be thinking about. But regardless, it's pretty well split between those three referral sources. But this volume of referrals, I mean, I'm the only person who does these for our entire catchment. And so, and I'm only a half-time clinician. So, it's like, it's a lot. And so right now, my teleclinic is 4 months out. Now, this is a clinic I built a couple of years ago specifically to try to address this increased volume. It's a more abbreviated clinic. It's run completely on telehealth. It's great for a lot of ways outside of just trying to reduce wait times. But my hope was to keep that clinic 1 month out at a time, so I could get somebody in and get them back, especially if he was considering about changing meds. And that's just not the case anymore. We've also seen such an increase in referrals that the in-person clinic is now 6 months out, which is not great. Now, community providers are somewhere between 1 to 3 years out for cases like this. So we're killing it compared to those folks. But still, these wait times are really, I mean, would it be overstating to say not acceptable for good clinical care? I mean, just waiting around this long, things change. And I would really like to see it decreased. So trying to figure that out is one of the issues that I kind of want us to be thinking about as we move through this presentation. Okay. And part of that is because ADHD is fairly straightforward. This is the DSM-5 criteria. The recent revision didn't really change the criteria, changed some stuff like, wording and how they look at associated symptoms, but nothing too much for the criteria. Now, you'll notice that it's 5 out of 9. That is the stipulation for adults. Kids are 6 out of 9 symptoms, but it should be pretty straightforward for diagnosing ADHD. But we all know that's not the case. ADHD is complicated because it has a number of different presentations. It affects many different contexts. There are external factors such as people believing the medication is going to be a silver bullet, people med seeking in general. Again, with the rise of ADHD education, which is sometimes poor, there's a real zeitgeist in change in that people see ADHD as a way of explaining and finally being understood and putting a lot of the things they've struggled with over the course of their life in context. And I think sometimes it can be an easy explanation for something that's much more complicated. So there's a lot of competing factors for people wanting to get this diagnosis, which makes evaluation difficult. On top of that, one of the things that I think we can all agree is that ADHD, especially in military populations, is very complicated because of the high comorbidity. So ADHD has higher rates of different mood disorders as well as substance use disorders. We know all of these things in adults can affect attention, concentration, impulsivity. making it really hard to discern whether a presenting issue within the clinic is related to ADHD or a co-occurring disorder. I also want to point to previous presentations at this grand rounds that I think are worth revisiting if you haven't seen them, or if it's been a while. I went back and tried to watch as much of these as I could. I watched them when they happened, and these are all within the last year or two. But there's obviously a lot of other factors that we have to consider. I think Dr. Litchfield's presentation on some of the literature pertaining to stimulant prescription was interesting. Obviously, Dr. Buchol's presentation on stimulus use disorder is a concern. For us as psychologists, we don't do the prescribing, but there is this way that I'm always really worried that if I put my stamp of approval on a case that I think is sort of middling, that I'm sort of giving permission for people to just get prescription meds. Like, it's sort of out of my hands at that point. So it is one of those things, like, even though I'm not doing the prescribing, it is something I'm concerned about, obviously. And then we also have just the age we live in. My wife, who is an accountant, extremely detail oriented. We're both in our 40s. We often joke about how we are both, have become extremely ADHD, given the high distractibility and the sort of different demands on our attention. So I think just having attentional issues in this age is much more common. And so I think that also increases people's concern that there might be something more going on, something underlying these changes. Okay. So additional comorbidities that we have here are like, we see this a lot in the VA. A lot of TBI is pretty common, which sort of makes sense with the behavioral impulsivity, excuse me, that you see with a lot of, especially like hyperactivity type. PTSD is really common. We've already mentioned substance disorders. Sleep disorders are really common. All of these things really affect attention and make it hard to tease out like what is going on with the presentations that you're seeing within clinic. Here's an interesting kind of like comorbid that I don't know if you ever run into this, but I do, because I get these referrals. So sometimes we will get individuals who've already been diagnosed with a neurodevelopmental disorder like autism, and they'll be referred back to me or to me for the first time to assess whether they also have ADHD. Now, this wasn't possible before DSM-5, and DSM-4, they were exclusionary. But there was a change made. And at one point, for a different presentation, I went through this literature because I was interested in this. And essentially, like, there's a lot of literature that says this is problematic, namely because even when you're giving like a lot of testing, you can pretty easily distinguish folks who have autism from people who have ADHD, because the autism measures sort of single out a lot of behaviors that aren't consistent with ADHD. But when you're assessing autism population for ADHD, there's a lot of symptom overlap, and it makes it really difficult to discern if this is a separate disorder, a co-occurring disorder, or if it's actually part of autism itself. My own opinion is that they made this move because providers and families wanted additional tools to help manage behavioral issues in individuals with autism and children. And they needed to allow that diagnosis to change. But I think it causes more difficulties in adults, because again, we're often getting people who, like, if someone comes in with a clear autism diagnosis, now they're also wanting ADHD, they also have trauma. It just becomes a really sticky and a difficult thing to discern. If you want to refer somebody like this to me, can you give me a call first or something? Because like sometimes this is one of those things, it's a really hard thing to do, and to disentangle this. All right. Okay. All right. So on top of just all that, I think all that's pretty routine. I think that for the most part, we all know there's a lot of comorbidities, that there's a lot of extra things outside the actual diagnostic process itself that is happening that makes it difficult. But we also get kind of these unique or edge cases that are difficult. And so I want to just get people's thoughts here. I have another survey. There's a QR code on there. I'll drop, see if I can. Gotta get back to the chat. Hold. Okay. There's the survey also. If you just want to click on that, it's fine. Or if you'd like to talk, I give you the survey so you don't have to feel like you have to talk, and I can actually hear from you. But if someone wants to say something, I mean, with the case like this, okay, this was, you know, I get these a lot, not a lot. I mean, I get these on occasion with people that are very high functioning, but they also think they have ADHD. So I don't want to give you a lot of information off the bat, but essentially, if you had a referral like this, in my case, it would come from psychiatry, but maybe if you're in psychiatry, it would come from BHIP, for example. But this person is like a project manager, a big tech firm, they have a PhD in mathematics, and they think they have ADHD. I want you to kind of think about like what you would want to know in order to assess ADHD. And I think in the survey I also built in like, what are your reactions to this? Because I think that's one thing that I notice a lot too, is how am I actually reacting to the cases that come in? And I've become more, I don't know, I've become more sensitive to that over time. So I'm kind of sort of stalling so I can get over to this actual survey here. Hold on. All right, interesting. So let me know if you can see, I'm gonna bring RedCap over. Can you all see RedCap now? Okay, cool. It's my first time using RedCap for presentation surveys. So yeah, so it's interesting. I really thought more people would be saying like, give me a break. But a lot of people are like, it's possible. This one here is, I've seen this before and could be an underlying issue. Okay, so 3 people, but the majority are kind of are just like open. Okay, great. Oh, and look at all these wonderful, look, we can just build an ADHD survey right here. This is awesome. Can you see that type at all? Is it too small? Thumbs down for too small. Thumbs up for fine. Fine for you guys. What about psychiatry? I don't know how big your screen is.
Oh yeah, you can see it.
You can see it? Okay, cool. So yeah, so age of onset, great. Why does the patient want care? Childhood functioning, wonderful. What was their environment like? That is great. Why did they think they have ADHD? This was not my term, okay? Brian gave it to me. All right. IQ, yes, usual stuff. Dysfunction, impact on work, grades in school. Yeah, I like this. Does somebody want to talk about, there's a handful of people that said, what would an ADHD diagnosis mean to the patient? Do people use this? Is that something does someone want to say? Who wrote that? I'm curious.
I wrote that. I think it's one of those that like I go through the criteria with patients who come in with an ADHD or wanting an ADHD diagnosis. But I think depending on how you screen, they can end up being pretty easily answered yes, especially in kind of modern society, which you've already kind of addressed with the like social media and attention spans. And so this is something I picked up from one of my attendings in residency, was basically like, what's the significance and like, how much does it mean to the patient? It kind of gives you an ability to start the conversation of like, do they want medications, where it's kind of really the impact? Are they looking for an explanation of like kind of their life history, or is it because they're just like not actually performing to the level that they should? And it
Yeah.
gives you, I feel like, more specific information to get to the level of impairment, I think.
Yeah, and like a great open-ended question, which I think in terms of assessment and any time of, diagnostic assessment is great, getting them to kind of talk it through, because where they go with that, it's very different if they're like, yeah, like I'm just really struggling, and I think if I took some meds, I would be better at what I'm doing, versus that sort of like, this helps explain. I've always thought I was a little bit off. I always made all these mistakes. I felt like I couldn't do anything well at school, even though sometimes I would test really well, but then I just never could follow through. Like by the end of the semester, I was always failing. I always do stupid things. I'm impulsive. I think there are different ways. I think definitely how they answer that question could lead you in different directions. Appreciate that. Okay. Great. We're going to come back to this. So hold on. Hold on to that. Oops. Okay. So let's just talk a little bit about like how we diagnose ADHD within like a standard psychological assessment clinic and go from there. So again, we're going to be focused on adults, but in kid we tend to emulate what they do in kids, because kids is where most of this diagnostic stuff happens and hasn't been more established. So the gold standard is really obviously do a thorough interview, go through and do a medical records review, get collateral records, which is vital. And like in a lot of kids and for folks that have done kid assessments, I mean, sometimes like a psychologist or neuropsychologist will give tons of different surveys, not only to the kid, not only to the parents, but to teachers. You're just getting like a ton of collateral information. Behavioral observations are really key too. Like oftentimes they'll observe kids over multiple sessions in order to pay attention to kind of to see how they interact with other folk, with people. And then obviously a lot of different testing, which may include like cognitive testing, psychological testing, whatever, looking at rule outs or other possible explanations for what's going on with them. And we tend to do the exact same thing with adults. I mean, for the most part, right? Everything, it looks a little bit different, but any sort of like good assessment is going to have this clinical interview, some sort of collateral interview or collateral record, review of medical records, symptom inventories, and behavioral observations. Collateral information is really key. So I think one of the main things that we want to do, in an assessment, we're trying to like build a pattern based on different data points, and we want this information to align in a way that's coherent. And when we start to see sort of like a discrepancy, and as those discrepancies increase, or if there's severe discrepancies, those are when we get concerned about the integrity of our data. So in other words, if someone comes in and they're reporting a high level of ADHD symptoms, but their parents are saying there was nothing there, then I'm getting, that's sort of getting concerned. Well, why is there that discrepancy? Because if you're reporting that like everything was a 10 out of 10 when you were a kid, but your parents are like, no, that wasn't present, that makes me concerned. Now, it could be that the parent just wasn't involved, or maybe they don't believe in ADHD, so they're underreporting. Like, we have to be careful about, but we're looking at, okay, where do these things align? Where do they don't? Every time there's this misalignment, we kind of note that down, because it's more evidence for us to be concerned about providing that diagnosis. For my clinic, because I need to be quick, I tend to give them surveys that I've collected. I used to work as I mentioned in the bio, I used to work at college counseling centers. And so I did a lot of these for ODS in colleges, which is much more extreme. I mean, we had to do intensive batteries and intensive data collection for these. And I'd use some of those, like the shorter forms, and just send them to the patient, have them give them to their parents, and then get them back to me. That's not perfect, but it's pretty good, and it's quick and it's easy for me. So that's what I tend to do. I don't tend to do interviews with parents unless I really have a concern anymore. All right, so neuropsychological assessment or cognitive testing. This got brought up in Dr. Litchfield's presentation that I'd referenced earlier, and I want to sort of nuance this a little bit. So we don't rely on cognitive tests to diagnose ADHD. And the reason that is because cognitive testing is not sufficient enough, it's not sensitive enough to distinguish between individuals with ADHD and those with ADHD or without ADHD. There's tons of research on this. You will see differences in population if you do a big research study between people who have ADHD and who they don't on cognitive testing. You will absolutely see differences, and there are differences. But when you're dealing with a unique individual, those differences are either so small or they're so varied that doing a cognitive battery to determine whether someone has ADHD is just not a thing. It would be nice because there's less face validity in something like cognitive testing, but that's just not the case. There are some exceptions, and like we use what's called the Connors Performance Test, and it essentially it's a computer-based test where they're going in and they're hitting a space bar anytime there's the correct target, and then trying not to hit the space bar when there are incorrect targets. There's like letters on the screen, and that really assesses like attention, sustained attention, impulsivity, and is designed to look at ADHD. And it's a pretty good test. You would never rely on it solely, but it does give you a sort of another window. But for most cognitive tests, when I would add those into the battery are when, one, they are going back to school, or we have and we want to look at their strengths and weaknesses. That absolutely can be helpful. Two, if there are questions about what is leading to, let's say, academic difficulties, if this is somebody who barely got into the military and had a very low ASVAB score, had an IEP in school and really struggled, but you're not really sure why, is it ADHD related? Like getting a pre-morbid intelligence and then a current IQ is kind of nice, because if this person does seem to be lower functioning in terms of IQ, that could help explain some of the difficulties they've had versus, oh, actually they have 140 IQ and they had that history, right? Like that's going to be very different, and you're going to look at that patient very differently. So cognitive testing is absolutely helpful for diagnosis. We just wouldn't use it solely for that diagnostic criteria. Okay. What gets shown over and over again to be the best in terms of like figuring out whether someone has ADHD are symptom measures. So just pretty straightforward ADHD symptom measures. The Winder Utah is one that that comes out again and again to have high reliability and high validity. It essentially assesses childhood symptoms. The nice thing about the Winder Utah is it's also free and it's available for use. If you pair this with something like the ASRS, which is the Adult ADHD Self-Report Scale, these go pretty well together because that one just looks at adult symptoms. So you have the Winder Utah looking at childhood, the ASRS looking at adult symptoms. They do really well together. They are available. We're going to loop back to those in a minute. But I first want to say there's one caveat, which is they are both like really prone to false positives. So a lot of the research that you see saying, okay, these are reliable and valid measures for using for ADHD, it's done in a vacuum. It's done in a research situation where they're getting people who have ADHD and have been diagnosed and people who haven't, and having them take these exams and answer honestly, and they're not really incentivized to be dishonest, right? They're not going to get anything out of it. They're not looking for a diagnosis. They're not looking for meds. So in those cases, they do really well. But when you get them out in the wild, they tend to fall apart because people who want the diagnosis, they're very face valid. So, you can easily discern, what you need, like if you want to have an ADHD diagnosis, you can easily figure out how to do that, right? And so you get a lot of false positives. And obviously this is a major issue. So if you just use those for diagnostic criteria, you're going to be in trouble because you're going to diagnose everybody with ADHD who comes into your office asking for it. In an assessment clinic, this is like one of the things, and I think one of the reasons we would refer to an assessment clinic is if you had any concern about malingering, or, you know, again, when you're doing an evaluation, if you start to see these discrepancies between, like, let's say collateral records, what you're seeing, how they're explaining their history, but they're reporting a ton of ADHD symptoms and you're worried about over-reporting, this is something that we can assess. There are two types of validity measures that we might use in a clinic. One is a cognitive symptom validity measure, and that's essentially a cognitive test that appears to be testing something like memory, but actually it's testing their effort. So these are tests that even at face value, they seem like, oh yeah, like they seem like they could be kind of hard and people might struggle with it if they had some real cognitive issues. But they're actually things that people, even with severe issues, can typically do pretty well. And if people are failing these tests, it indicates that their effort is poor. There's a lot of reasons for effort being poor. One is malingering. One is being like, I want to appear sick, so I'm going to do poorly on this test. But another reason is that they're drunk, or they're delirious, or they are, you know, they don't care. They didn't want to be there, and they're just going to be random and difficult. So there's lots of reasons. But there's some research, like on ADHD, for example, like if people fail 3 of these, it's like 100% positive predictor they're malingering, for example. I mean, that is a research study, but you know, the more they fail these, the more likely they are not putting forth the effort because they're intentionally trying to fake bad. The other way that we look at this is using broad personality measures like the MMPI-2RF. These are tests, obviously, that have like over 300 questions, and they have these embedded validity measures, and they're quite nuanced. You can see this diagram here that you have a number, like all of these are validity measures. Some of them look at like underreporting, and these all look at like overreporting. And you can sort of tease out if they are, you know, reporting symptoms that can occur, but they're but if it's elevated, it's more like a cry for help, unless it's really bad, versus really rare symptoms that no one really ever reports, if they're somatic symptoms, if they're associated with malingering. And you can also see if, like, is this occurring because they're randomly reporting? In other words, the test is nice because it gives you a lot of ways of looking at how they're reporting so that you can assess sort of the quality of their report. And when I do an ADHD eval, I will give this test not only for the MMPI itself, but also to kind of give a sense of how they might be responding on these other symptom validity measures. So if I give a Wender Utah, for example, and they're highly overreporting and the MMPI is valid, I can assume that likely the other testing is not valid as well, or is concerning. Like, you have to, again, that's sort of one of those things where you're like, okay, I can't take these surveys as face valid. And so I want to be looking at how might there be these discrepancies within this from the surveys connecting to the collateral records and other information. I won't always, you know, just dismiss the case and say, well, I'm not going to diagnose it, but I'm going to be much more suspicious and need a higher bar of information before I would move forward with a diagnosis. Okay. This is just more data on what I was saying. For the psychologist here, just a note, PAI is not good at this. So if you're going to be using, I would say if you're going to use a test, you know, something, a large psychological test and want to have good validity measures, I would stick to the MMPI and I wouldn't use the PAI. But you probably know that I'm not a big PAI person anyway, so take that with a grain of salt. But there is research on that. Okay, so here's the gold standard. Obviously, we want to pull these things together and be looking at these patterns and seeing how consistently they align. So we looked at some of the things you wanted to know, and I think like you all have really wonderful instincts about, okay, how can we pull this together with, what do we want to look at in this case that I presented, and how can we use that to kind of help understand ADHD? I'm realizing I did way too much of a presentation. I've got like at least an hour and a half more. I'm so sorry. That's terrible. Okay. All right. So, but we'll work through this case. I want to leave a little bit of time to talk here. So here's the presenting issue. Like essentially, again, I don't know if I mentioned this. This is a case that's based on a case that I did, but not the exact thing. I like changed a lot of the stuff. So, just I want to kind of get a sense of your impressions here. So this is a veteran, highly successful since leaving the military, but he often feels scattered, often starts numerous projects at the same time. And he does this in order to feel engaged. So he's kind of like doing a ton of different things. Otherwise, he starts to get distracted and he starts to sort of get very antsy. He often wants to jump from one thing to the next. He's been successful, but the way he's been successful is through overworking, like working an excessive amount of hours, and he becomes like really kind of obsessional about what he's doing. He has a family history of ADHD and addiction. This is another thing I didn't really mention, but like one of the things I give is a developmental history form, and I think looking at risk factors, obviously like family history, but like maternal smoking and drinking, perinatal heart conditions, things like that, I think is helpful. So he's got some family history that's indicative. All right, academic history before age 12. So this is important too, right? We're looking at the prior 12 history, and you kind of want to be clear with people, because sometimes you're like, okay, do you ever struggle in school? They're like, yeah, I took some summer school when I was a junior in high school. And it's like, that's fine, that maybe that's helpful, but that's not what we're looking at, right? We want prior to 12 history. So this individual, average student who had little drive and difficulty focusing, difficulty with focus, but his parents were really strict. So he was able to get by with a B average, was never required to retake classes or take remedial classes. On the face of it, this is not a history I would say is consistent with ADHD. You know, like I'd really love to see, that sounded bad. In terms of making the diagnosis easy, I would really love to see like, I was on an EEP, I did get tested for ADHD, I was diagnosed. Like that's super helpful, obviously. You don't always get those cases. This is sort of like a middling. I mean, there's lots of reasons for someone to have this sort of academic performance before age 12. So this kind of like, okay, what's going on here? Obviously, we know the history with him getting a PhD in math. So it's like, how did that happen? Interestingly, he ends up not really knowing what to do, applies for the military, and just like blows out the ASVAB score. And then gets like an Intel position and starts getting trained in cryptography and gets obsessed with it. He gets put in a pretty high level security clearance. This is during the conflict, so he's constantly on these like high-end missions. It's like meaningful work. He's getting this constant reinforcement about how good he is at this. He finds he's really good at math, and just begins to excel. So as soon as he gets out of the military, he immediately goes into college. He gets a degree in mathematics in 2.5 years with a 4.0 GPA, working probably 80 hours a week, completely obsessed. If any of you, I'm sure most of you have taken like college level math. I mean, to get a C is hard. To get an A is like really hard. So like, and he's just like clearing it. And then he ends up getting a full ride for a PhD program and finishing that PhD in less than 4 years. So this is like one of those weird cases where on the one hand, you look at that college history and you're like, there's no way in heck this guy has ADHD. But then you look at his academic performance before age 12, and it really looks like that pattern of a gifted individual who struggled with attentional issues, motivation, and sort of got in this situation where they all of a sudden they were good at something and they became obsessed with it. And now he works at this global tech firm thing. Testing was no over-reporting. ADHD screeners were positive. Another QR code. You can grab that really quick if you like. Try to grab the last thing. I'm just curious about what people think. I'm trying to. All right. I'll put the link back in the last link here. If you're interested. Does anybody have any thoughts about this case?
Cody, I just have a question. How
Yeah.
are his social skills?
I mean, he's married.
Okay.
Yeah, that's a great question. So yeah, I think okay, like he's married. He tends to like so he's a project manager, which seems like, oh, you got to be hyper organized, but he tends to like manage his team like a whirlwind, and sort of just like runs around and is he's kind of really involved in a lot of things and has a team that kind of helps him, in some other ways. The one of the major issues, I can't remember if it was on there or not, is that he recognizes that he's constantly moving his family around to one thing after the other. And actually, when he came in to see me, was actually thinking about pursuing another PhD program because he was starting to get bored because he felt like his job just like he felt like he needed something more to keep himself kind of moving. All right, I'm going to grab this survey here. Let's see. All right. So a lot of folks saying no, but I would keep it as a rule out. Yes, but provisional. 1, yes, for sure. 2, no, this is clearly not. It is interesting. What do people in this big group? I mean, what is it that makes you think no, but a rule out?
I wondered if his anxiety is treated.
Yeah, that's a great question. So, and I didn't have that information. So that's like more information you want to know. So this is somebody who's been engaged in treatment, is on meds. I think GAD was like maybe like a 9. It's GAD scale, but definitely has a history of generalized anxiety for sure. Anybody else? Okay. So just to, there's one more point I just want to hit on. Well, I'll just do this quick. Let's see if I can get back to my survey. One is, one thing that I would sort of like leave you with, and we could probably do more of a presentation on this, but BHL Touch is available. If you don't, I can't put it in there now, but I have the link. I can throw the link in the chat. So anybody who's at the VA, you can use this, use BHL Touch. And they have both the ASRS and the Winder Utah in there. And so the nice thing about it, it's used for measurement-based care. You can send it before the person comes in, they fill it out on their phone. You can send it after the clinic, you can get it back. You can publish it into CPRS and get all the information. And then what I would recommend doing with a lot of those, again, they will likely be positive a lot. One, pay attention to the score. Even though the cutoff on the Winder Utah is a 36, a lot of research shows like 58 is more the mean for diagnosis, and normative controls are around 17. So you want to be a little bit stricter on these things. Also, when you're looking at it, there's actually 3 factors. There's self-esteem, negative mood, attention, inattentiveness and school problems, impulsivity and behavior problems. And that's important because a lot of times what you'll end up getting, I'm just gonna go right to this for now, because I think the Winder Utah is probably the most important. What you'll end up getting is you'll see like this pattern here. This is only the first 6 questions, but you can kind of notice, right? Like you have concentration problems here, inattentiveness. These probably load onto the inattentiveness subfactor, where 5 and 6 probably load onto the behavioral issues, and then 2 and 3 probably low onto the mood, right? And so this pattern here, like, okay, maybe there's some behavioral issues, but I think it's this pattern that you're seeing here where they're kind of moderate inattentive symptoms, but a lot of mood issues and behavioral issues. If this is somebody who also had chronic childhood abuse, you could have a really positive Winder Utah, and they're reporting honestly, but it's probably less likely ADHD, or at least there's a complicating factor, right? You're not going to look at this. So it's really good to kind of, if you use these, I would recommend that you use them as like structured interviews. So going through and actually looking at the responses and seeing where things fall. And then you could even use something like the SKID method. So if you used the SKID before, it basically uses this like 3-point, this like 0, 1, 2 scale. And in order for a trait or a symptom to meet to be relevant, clinically significant, it needs to be a 2 on this scale. So 0 is like, it's not there. 1's like kinda, 2 is like, yes, it is a clear symptom. And in the SKID, it's more complicated, but generally it's like, are these symptoms, got a typo there. Do these symptoms persist across time and context? And can they provide really clear examples? So that's one thing I would recommend doing, because with the structured interview, you kind of dial in and be like, okay, like when do you remember, when did this start? Was it a real problem all the way through school? Like, what about in other contexts? When is it not a problem? And then like, can you give me clear examples? And I think obviously remembering childhood is tough, but it's like, if they can't give you clear examples, then what are they basing their recollection on? If they're just sort of like a general sense, or what they what they think we want to hear for diagnosis, then you're going to be less trustworthy of that report, right? And need to be looking at other sort of data sources. Okay, so that's how I would use those. With this logjam issue, I want to leave just like, have you all seen this algorithm? Can I get a raise of hands for people on screen? I would be interested in psychiatry. Have you seen this algorithm? It's from Harvard Review. Maybe. Okay. Dr. Kelly and I did this, like I did a presentation with Dr. Kelly a long time ago. And this is something that she found. I think it's really cool. This is an algorithm that's designed for the sort of people coming through primary care and going through our hospital algorithm. It's not for VA, but it fits really well. And essentially, this is something that I think is really designed to decrease prescriptions. Like, it is something that if we modeled this, it would absolutely decrease prescriptions, because essentially what we're looking at here is when someone comes in, if they have any other co-occurring disorder, we're going to treat that first. And essentially when those treatments are completed, and I think I steal something from my old physical therapy colleagues, which is like the patient has maximized treatment, meaning like it doesn't mean that like, oh, they're 100% success, they've taken EMDR and their trauma is like way better, but like they've tried it, they've done their best, and this is as good as they're going to get with this treatment, right? In this amount of time span. So once they do all that, then they can go back and be looked at to see, do they have symptoms prior to the age of 12? And go through any sort of like behavioral intervention for sleep or organizational training. If that stuff still happens, then you refer them over eventually, and they would go into this algorithm to look for medication, right? Now, one thing about this model that's sort of it reminds me of is sort of some of the things that we tried to do during the opioid crisis. Again, I was the pain psychologist here for a lot of years, and we really tried hard to figure out ways to divert people into things other than just going straight to medication. Because of where we were at with the opioids and opioid prescriptions, we had to build a lot of services. It makes sense. When you know, it is agreed upon we have an issue with the way we're treating folks, and that, you know, these medications have become out of control. I'm not saying they have, and I think like some of those presentations that I put in there are worth revisiting from people who know more about this than I do. But I also think like it also makes patients really unhappy. You know, they feel like they're jumping through hoops, like you're just stringing them along. So this kind of algorithm is great, but I think it also can be a pretty difficult thing for the hospital to manage and us as providers, because your patients are just going to be mad at you and feel like you're not really listening to them, right? I see some head shaking. So I don't know. I like it, but I think it's tough. This is something that recently came to my attention when I was preparing for this, which is Academic Detailing actually has a pretty nice website with they have a SharePoint site and they've done a lot of work on ADHD. They've actually got like a contact line. You can call people to ask questions of the experts. They have a bunch of tools they've made. They have an algorithm they made. They have a bunch of presentations. So it's pretty good. I like it. And their algorithm is very different. All right. It essentially, it's much more streamlined. It doesn't sort of like run people through hoops. And it seems to be aimed at trying to create points where we can assess ADHD in a way that is feasible for our clinics, and can get people into care quicker. And so, for example, this first decision point, you essentially have a patient coming in, and they are given this brief ADHD identification tool. You can find this in CPRS in the shared templates now. They're there. It's really fast. It's just a few questions. If they're positive, they also get an ASRS, and then they would be referred to a more full evaluation. This is something that can be done in primary care really easily. If they are not, then it's just a no and they're out of the algorithm, right? The full assessment is another template. It's much more detailed and it goes through a lot of the comorbidities. It can be done by anybody. It can be social work, psychology, psychiatry, any behavioral health provider that's qualified to do like a diagnostic eval, just like you would for BHIP or something. And it goes through that whole thing. This is the decision point where they would be diagnosed or not with ADHD. Okay, so if through this process they get an ADHD diagnosis, then they're going to be referred. They would go to psychopharmacology or different behavioral treatments, whatever you have at your hospital. If it's a no, but it's still kind of unclear, it's at that point they would be referred to me. So I like this. This sounds great. I know we only have a couple of minutes, or like 1 minute, but I'm really interested in like what if you think this is something that would work, or if you think like this would make things worse, or does somebody want to throw me a bone and say something, because I know we're almost out of time. Psychiatry, please. Do you think this would be help, or would this make things worse?
Yeah, I mean, I think it would be helpful. I think the same problem though, like you're saying, right? It's like, are we diminishing the therapeutic alliance with the patient because we're doing like X, Y, and Z when they're asking us for something specifically, right? And I think it's tough because of I think it's hard for us to know like what we're treating. Are we treating the fact that you have a really difficult job and that like your demands are like increasingly severe, and so like we're treating a societal problem
Yeah,
on an individual level. And I don't know if this necessarily takes care of that, which I think is really tough.
totally fair. I mean, maybe the issue is just get more of me, right? Get more of me, do more assessments. It's totally fine.
Yeah.
Yeah, that sounds great. Yeah, I think like this would make a really cool QI project, honestly. We've done something like this before, but I didn't follow the work that much. There was one last year. But I mean, I think in general, like something needs to be done just because it feels a little out of control at this point.
Yeah.
It is an issue across multiple clinics, across the healthcare algorithm. And so, yeah, I appreciate it. I wish I had more time to talk. If you have any questions, let me know. I'll try to bundle all this together, including some of the resources, and get those to Deb to get out to people if they want it. And I appreciate your time.
Thank you so much.
Thank you.
Thanks all.